and I want to make sure that we don't make you guys stay any longer than absolutely necessary. So good morning, thanks for tuning in. We're going to be covering respiratory emergencies in 72 slides. So the material we'll be covering is going to be anatomy, gas exchange, basic management, respiratory conditions, CPAP, and end-tidal CO2. Starting off, we'll be talking with the respiratory system comprises the sinuses, the nasal cavity, the oral cavity, the pharynx, the larynx, the trachea, the lungs, down to the bronchioles, the bronchi, bronchioles, alveoli, as well as the ribs, the accessory muscles associated with the ribs and the diaphragm. And our whole entire respiratory system, we kind of think of it as mostly dealing with inhalation, exhalation, and gas exchange, but it's also a good reminder to talk about that it's also responsible for our ability to talk, to smell, regulate our temperature, and humidify our air, as well as protect against irritants. Gas exchange occurs in these basic 4 steps. Your airway inhales air, it warms it, it humidifies it. The negative pressure created by your lungs, your ribs, your accessory muscles, and your intercostal muscles, you can think of in your sternocleidomastoid, and your diaphragm create a negative pressure to allow you to inspire and expire. And then the surface area of the alveoli allow for gas exchange, both oxygen and CO2. And then our hemoglobin are responsible, obviously, for the ability to carry oxygen. Basic management is kind of reiterated throughout all of the slides, but I think it's probably a good thing to hit it home over and over. So we're going to be doing our initial scene size up, making sure that if the spine needs to be protected, that's one of the first things we do as we quickly navigate through our primary survey and work on maintaining the airway. Any patient that's in respiratory distress should receive oxygen. You can be selective if a person says they're short of breath and you're not necessarily convinced that they truly are, but if they are in respiratory distress, they should get oxygen. Any patient that's suspected of being hypoxic should also get oxygen. There's no reason to withhold oxygen if they are hypoxic, and the value we're shooting for at sea level is 94%. And then a trial of CPAP is appropriate for any dyspnea. You don't have to try to figure out if it's one particular condition over another, as long as they meet the criteria for the prerequisites for placement of CPAP and they don't have any contraindications. So moving on to respiratory conditions, I kind of broke this up. Looks like 2017 might have been the last time you guys had this lecture, and so I broke it up kind of anatomically. So obstruction, negative pressure, and surface area, negative pressure, and then oxygen carrying capacity. But we'll move forward and you'll see that breakdown again. So obstruction. Upper airway obstruction, indicated by this purple box on this cartoon, is any kind of narrowing or occlusion to the anatomy of the upper airway, and it leads to decreased ability to ventilate. Usually we deal with the acute issues, we as pre-hospital and emergency medicine combined, either that's from a foreign body or for anaphylaxis, but there also can be chronic conditions that can lead to obstructions such as malignancy. And then the obstructions can be partial or complete, and depending on what type of obstruction we're dealing with, the partial or complete dictates how we manage it. Common causes for obstruction can be enlarged tongue, foreign body, trauma to the airway, either oral, nasal, pharyngeal cancer, any type of narrowing of the trachea, such as atresia or a tracheal web, kind of redundant tissue that prevents for adequate patency. There can be inflammation, such as an allergic reaction, any type of infection. One of the things I think we commonly think about, even though it's not as common now, is epiglottitis, croup, but also we should be thinking about paratonsillar abscesses or retropharyngeal abscesses such as Ludwig's. And then any kind of burns, which can be chemical or thermal. We should be trying to differentiate the cause as quickly as possible so that we can treat the underlying condition appropriately. And that we want to be doing a good exam of the head and neck to make sure that we're trying to figure out the etiology for the patient's obstruction. And then at the same, this next slide. So if a patient has a partial airway obstruction, you're going to want to assist them more than anything. So have them sit up so that they can increase their ability to expel that foreign body if it's an acute external reason for them to have an obstruction. And that if they don't clear it themselves or you think that they may have aspirated, would be an indication to transport. If it's a complete obstruction, we're moving towards when we really intervene. So AHA protocol for obstruction. If the patient's unconscious, you can attempt to try to remove it with the McGill's. And we talked about this, I think, in case reviews in May. If you can't remove it, then you're moving, and you can't ventilate, then you're moving towards becoming more invasive in your treatment protocol. So that might be getting ready for a crike, but it might be worthwhile to try to right main stem that foreign body to ventilate at least the left lung. And then, of course, if it's a pediatric, we're not doing a cricothyrotomy, we're doing a needle jet insufflation. And that all of this, as we all know, needs to be done quickly with all of the equipment necessary for escalation of care readily available so that we can move from one regimen to the next if that fails. So upper airway obstruction secondary to edema. Angioedema, it can be hereditary or medication induced. The two images on the right-hand side is representation of angioedema. The top one showing a tongue that may not necessarily look all that swollen, but the video laryngoscopy showing how swollen the epiglottis is. And then the image below before and after for this particular gentleman that I pulled from a hereditary angioedema paper. Anaphylaxis, croup and epiglottitis, kind of representing this kid that has his eyes blacked out. Epiglottitis used to be more of an issue when we had children that that didn't get vaccinated or that before the H flu vaccination came out, and then burns. And then croup, of course, croup being an upper airway edema incident where we hear them as kind of like a barky seal cough. So going over our protocols for upper airway edema, well, I try to tie that into a lot of the slides that we're going to look at, but this one was just easiest to pull it right from our protocol. So croup and epiglottitis, if it's a patient that's at least 20 to 40 kilograms that has stridor, we have the option to give them racemic epi. And if we, don't have racemic epi readily available, or I guess if racemic epi fails, you can also use epi in a nebulizer. If the child is under 20 kilos, prefer that you're using racemic. And if there's evidence of anaphylaxis in foreign body, we proceed with the adult guidelines mentioned in the foreign body slide earlier. If they're having difficulties with ventilating, then we're moving towards bag valve mask, and if that fails, towards intubation. And then as for anaphylaxis, as a review, mild reaction is going to be Benadryl, severe reaction will be Benadryl, in addition to epi, in addition to albuterol and Solumedrol, and potentially even a norepi drip. Remember that dexamethasone is an alternative to your Solumedrol. All right, and then another potential cause for edema impairing the upper airway would be burns. I think that I tried to get this video to be a loop, but it's another great example of bougie first. You've got a very edematous or a very soot-filled airway and vocal cords that are pretty swollen, in that this video shows that they used a bougie first to secure the access to the through the vocal cords, and then place that ET tube over it. This was actually came from my residency page, the HQ med for Hennepin. But so burns, just singed nasal hairs and facial burns alone would not be an indication for intubation. Mild inhalational injuries with normal O2 sats and no respiratory distress can oftentimes just be monitored. And then depending on where you look at, you can find that there's a lot of disparity to what would be the indications to intubate a burn victim. But I think that what we have in our protocol in Clark County is great. And then I added the italicized one. But signs of respiratory distress, such as stridor, accessory muscle use, they have a new hoarseness. There's evidence of thermal burns to the oropharynx, such as bleeding, blisters, or edema. There might be deep burns to the lower face or neck, which you would assume that there's potential compromise to the upper airways. And then altered mental status, assuming that that's related to the burn or hypoxia, in that they are unable to protect their airway. So next category for conditions that compromise negative pressure. So those going to include obstructive pneumothorax, anything nervous system, hyperventilation syndrome, and then upper respiratory infections, but we'll be focusing only on pertussis. The image on the right here shows that between the phases of inspiration and exhalation, that overall intrapleural pressure is negative, allowing for the alveoli pressure to completely, I'm trying to think of the word I want to use, deflate. So starting off with inspiration, you've got a -5 for intrapleural pressure, in that at the end of inspiration, it's -8, allowing for there to be a negative gradient to expire. So we're going to start with obstructive lung disease, which includes emphysema, chronic bronchitis, and asthma. The causes can be multifocal or multitude of potential possibilities, such as genetically alpha-1 antitrypsin deficiency, smoking, occupational hazards that might induce it, air pollution, or a propensity for the patient to have airway hyperresponsiveness. It's important to note that up to 20% of smokers never get COPD, so obviously smoking is not a direct cause and effect, but oftentimes 80% of the time it's related. And then diagnosis would be with spirometry. I'm not sure if we have spirometry at all in the pre-hospital setting. Can anyone speak to that?
No, we do not.
Okay. So it's something that we used a lot in my residency, and I can tell you that in clinical practice outside of an academic center, we don't use it in the emergency room setting either. It's unfortunate, but we used to use it to guide our FEV1 pre-medication and post-medication, and allow us to figure out who's safe to go home, which might be helpful for who's safe to stay on the scene. But spirometry is used to identify what type of obstructive lung disease, if you have COPD or asthma. The images here on the bottom right-hand side, or the bottom side bottom right-hand side, show what spirometry, more sophisticated spirometry, would be able to identify. The image on the left would be something that even a handheld spirometry like this one that the patient's using in the image, but it's a deep inhalation and forced exhalation or expiration. That FEV1 is the forced expiratory volume in 1 second, and then the remainder is what resumes in 6 seconds of exhalation. Normal is indicated by the blue, and obstructive is indicated by the red. So you can see that in 1 second, the amount of volume that a patient can expire is substantially diminished or reduced in an obstructive pathology. The image here on the right, these flow volume loops, I'm not going to spend a ton of time on it, but obstructive lung disease, you're going to see a low peak inspiratory flow and a low peak expiratory flow. I think one of the things that is important to look at when you're looking at this is that there's never, the expiratory flow never reaches zero, so it really sets them up for air trapping. And then with the restrictive lung pattern, which is represented in the blue image on that, is that overall you're going to see lower tidal volumes, a rapid decrease in inspiratory flow, and a rapid expiratory flow, as you can see there. So pathophysiology related to both bronchitis and emphysema. A lot of where you'll potentially read and review this is that emphysema is bronchitis chronically, that so it's a two conditions that or bronchitis that is required in order to reach COPD pathology, but you're going to have excess inflammation and mucus production, which leads to breakdown of the alveoli, decreasing the amount of surface area for gas exchange and making it more difficult to completely expire the residual volume. Emphysema, their patients are oftentimes barrel-chested just because of the course of their disease. They often have hyperinflated lungs, so more barrel-chested as well. They have a prolonged expiratory phase and a rapid rest phase. They tend to be thinner because of the amount of energy is required to just with work of breathing in normal state. They're usually more pink due to increased red cell production from their chronic hypoxemia. And then there's increased development of their accessory muscles. Chronic bronchitis usually is a result in increase from mucus secreting cells in the respiratory tree. The alveoli don't necessarily need to be affected, and that there's a decreased alveolar ventilation because of the mucus pooling. The patients tend to have frequent respiratory infections, oftentimes complaining of a productive cough. Chronic bronchitis patients are typically overweight. They might have rhonchi facilitate them. I would say that more so with pulmonary edema, you'd want to listen to the back of the patient, unless they're a thin patient, but represents that if you do have a patient that has a lot of redundant tissue, breast tissue in the anterior aspect of their chest, that auscultation to the back, it might actually produce better acquisition of lung sounds. And then if you're looking for something that's gravity dependent, listening to the bases would be helpful as well. There might be jugular vein distension, pedal edema, or hepatic congestion. One of the things that you may have heard when you drop off a patient in the emergency room is that when we have a COPD patient that comes in with exacerbation, respiratory distress, that we ask them if there's been a change in sputum, which often dictates if they'll get antibiotics, regardless if their chest x-ray shows an infiltrate. So bronchitis and emphysema management, you're going to be allowing the patient to be in a position that's most comfortable. Most of your patients are not going to want to lay flat or be in a semi-Fowler's position. They're going to want to be sitting upright. If they are having difficulty with breathing that you think that they could benefit from, CPAP, place it. It'll help reduce their work of breathing and decrease the chances of fatiguing. If CPAP fails, you're moving towards intubation. You want to have access on them, both for potential medical management in the acute phase, but also if you're moving towards RSI, place them on the monitor and get a 12 lead because they're usually prone to dysrhythmias, especially AFib. And then treatment might include albuterol, Atrovent, Solumedrol. Anybody that you're dealing with COPD, and actually I would probably say anyone that you think is in respiratory extremis, the importance of capnography. Capnography might help you in identifying what kind of condition you're having. We talk about this later in the lecture, but you'll see a sawtooth kind of pattern with your obstructive lung disease, COPD, and asthma, in that you can also use the capnography to guide your management. Be aware that patients with COPD will likely have a little higher end-tidal CO2 at a chronic state than your patients that have no underlying respiratory issues. So for asthma, it's a chronic inflammatory disorder. It results in widespread but variable airflow obstruction. I tried to put in some audio stuff for you guys.
Hi, it's Stacey Abrams.
No, that's not
There
it.
is a huge fundraising deadline for Senate Democrats, and they need your help right now if they're going to meet it.
There you go. So wheezing, for those that are newer to this profession, may sound like that. The airway becomes hyper-responsive in that a trigger can be variable depending on the individual. Maybe it's from a recent infection, maybe it's environmental, like if actually in current situations, if there's a large forest fire or smoke in the air, that can be a trigger for a patient, a lot of wind. But the trigger would lead to histamine release, which causes bronchoconstriction and bronchial edema. And then that's further exacerbated maybe 6 to 8 hours later when the immune cells invade, causing further edema. Oops, there you go. This is a cartoon of the pathophysiology with an asthma attack. Basically, the image on the bottom right would be somewhere you should focus more on. So you're going to see that the smooth muscles are contracted or constricted, that there's a lot of edema. Some of it's related to the blood vessels infiltrated by immune cells, and that there's increased mucus production. So overall, you have a narrow airway passage and a lot of inflammation. So your assessment of your asthmatic patient, you're looking for someone who's an extremist. So anybody that is having any kind of dyspnea, but specifically somebody who's near respiratory rest. So someone who's maybe 1 to 2 word dyspneic, decreased breath sounds or absent breath sounds. They may be tachycardic, and depends on if they have any kind of agents that might prevent them from being tachycardic. So that's not a 100% correlation. And then decreased oxygen saturation. I'm trying to remember if anyone wants to unmute themselves. Our MedNebs, are they handheld or are they masks? I think they're masks here. Can anyone speak to that?
We have both.
Okay, so when I worked as a medic, we really liked the handheld nebulizers because it allowed us to get a gauge when a patient, and that was pre-end-tidal CO2. So, but anyways, it allowed us to get a gauge of when a patient was starting to fatigue out. If we found ourselves asking them to put it back to their face and to breathe in and breathe out, and it wasn't just because they were distracted, but because they were fatiguing to the point that they couldn't even hold the nebulizer up to their face, that gave us a gauge as well of nearing respiratory failure. So I would put that as a consideration under identify immediate threats. And we would move towards putting them on a MedNeb mask if we thought that from the get-go, we saw them and we thought they were moving towards intubation. So sample history, OP-QRST, always for all your patients if they're able to provide it. And anybody that has previous hospitalizations are important to know. Anybody that's ever been intubated in the past, it's important to know. Oftentimes, if you don't already ask this, you can ask, how does this compare to that time when they were hospitalized or they were intubated. And then another question that I would add to this is that have you been treated for a COPD or an asthma exacerbation in the last 30 days? Have they recently been on steroids? The chances are pretty high that they shouldn't be left at home, for one, because they've already had a trial of steroids and failed that in the recent past, and that the chances are higher that they would likely need to be intubated because of that they've already recently had an exacerbation. So physical exam findings on asthmatics can be dyspneic, wheezing, cough, although wheezing is not present always, especially if they're absent with their breath sounds. If their speech is limited to full sentence or 1 to 2 word dyspnea, that's important to recognize. Look for evidence of accessory muscle use, hyperinflation, and then you want to oscillate their breath sounds. And I would probably use your peak flow, expiratory flow rate for patients that are not in extremis. Our goals for treatment on our asthmatics, again, is just a review since we do this often. We're going to correct their hypoxia by giving them oxygen. We're going to give them bronchospastic agents to dilate their bronchioles or their alveoli with our albuterol and our Atrovent, and we're going to reduce inflammation with steroids. We're going to maintain their airway as best as they are able to do on their own, and we'll support their breathing with external devices, potentially continuous pressure airway devices such as CPAP, and then maybe even needing to assist their ventilations. If a patient has known as, so our protocol says if known asthmatic and having a recurrent attack, you can give the agents that we talked about, adding the consideration for magnesium from a previous slide I talked to you about. I would say if your patient has wheezing and you suspect asthma, that you should also consider these. And then one other section in our protocol is that if we're using our CPAP, we should be trying to not have our settings above 5 centimeters of pressure. Any questions? All right. So upper respiratory infections, URIs. We're focusing from previous lecture on just pertussis, so whooping cough. In Colorado, there was an outbreak of whooping cough. I think that was probably related to under-vaccinated. And I don't know if we've had an outbreak or we have a lot of cases in Washington, but I assume that we must because we have it in a previous lecture for respiratory emergencies. But it's caused by Bordetella pertussis, which is a bacteria. It's highly contagious. It's spread by airborne droplets, and it's becoming more prevalent. It's interesting because it's hard to differentiate from any other type of upper respiratory infection, which oftentimes is just viral. And then after a week or two, then you start to have the more paroxysmal fits or the whooping sound cough that we're used to describing as kind of pathognomonic. I'm hoping that this video starts where I want it to.
Pertussis. Whooping cough is also known as pertussis. It's caused by a bacteria infection that is spread from one person with whooping cough to another person.
What is he doing? Dr. Thomas Boyce says whooping cough is particularly tough on kids younger than Pedro, who haven't had the full course of vaccinations given at 2, 4, and 6 months.
They're particularly susceptible to getting infection, and because of their small airway, they're particularly susceptible to having very severe disease.
You see, the infection happens in the airway or trachea. The pertussis bacteria produce toxins that irritate and inflame the airway. This causes the severe, repeated cough that lasts for months.
They call it the 100-day cough.
Pedro and his entire family.
So that's just kind of a review of pertussis, but important to kind of hear that little kid's cough. The next slide will also have another, oops, yeah, perfect. 2 slides from now, we'll have another video of a kid coughing. I would say that pertussis is a pain in normal, healthy adults, but in our extremes and ages, it can be potentially life-threatening. So this is a image showing the course of the disease. The first week or two, they're going to present as kind of our typical upper respiratory. Anywhere from 1 to 10 weeks, they are going to have more of the paroxysmal stage. We'll have the whooping cough component, and that it can be so profound that it leads to a respiratory failure from fatigue. And then the stage 3, or the convalescent stage, is that they'll have lesser symptoms, but this may even proceed for another 2 to 3 weeks. So you're looking up to 12 weeks of illness. Okay, and then this is another video of an infant who just want to help her breathe.
Okay. It's okay. Okay. It's okay, honey.
Following the paroxysms, you can have apnea, which I would say that she's trying to breathe, but she is, for all intents and purposes, not passing any air until she gasps. And then you can hear the pulse ox stat alarming in the background, so you can only imagine how low her O2 stats are. So treatment for us is going to be supportive. We're going to want to have appropriate PPE, not triple PE, and prevent exposure. So trying to minimize who comes in contact, probably put them on a mask to try to keep this respiratory droplets from when they're coughing to a minimum, I guess, exposure. And then oxygenation with humidified oxygen. You can try a beta agonist, and you may need to assist their ventilation. For the emergency room setting or the hospital setting, antibiotics are started to try to, in the early URI stage, to try to minimize the extent of their disease, and then in the paroxysmal stage to try to decrease the chances for infecting others. I think somebody's still unmuted. All right, so pneumothoraxes, we're going to talk specifically just on regarding spontaneous pneumothoraxes, and that's when they occur without trauma. The risk factors for spontaneous pneumothorax is usually male, young, tall, thin, smoker, family history of pneumothorax, spontaneous, and previous pneumothoraxes in themselves, if this is not their first presentation, and then sometimes related to forceful coughing, and there's been some correlation with pregnant females. Assessment, you're going to be repeating your sample in OPQRST as the patient's condition allows. You're looking for risk factors, how quickly those symptoms started, what were they doing. Sometimes they might have an associated history of lifting something, and that they may be presenting with chest pain or shoulder pain in addition to shortness of breath. Be aware that if your patient has had recurrent pneumothoraces, there's a good chance that they might have scar tissue or complications from the healing of previous pneumothoraces and chest tubes that may make it more difficult to decompress them. But if they're in extremis, you move forward with decompressing them. So physical exam, they may have decreased breath sounds on the affected side. Vital signs might be tachypnic, tachycardic. They might be diaphoretic. You're going to be mostly supporting their airway unless you need to intervene because your suspicion for tension pneumothorax is developing or you believe that it's present. So you'll be decompressing them if they're cyanotic, they're hypoxic, potentially hypotensive, or difficult to ventilate. And that if you are seeing JVD and tracheal deviation develop during your visit or your encounter with the patient, that's a bad sign. Hopefully that's something that had been present from the initial assessment. This image on the right here kind of shows you an example of, so this is the patient's right, and you can see that you don't see any lung markings like you see on the left-hand side. So this is, there's an absent or collapsed or compressed lung, and that the trachea is deviated over to the unaffected side as this air continues to accumulate and push everything to the contralateral or the opposite side. So CNS dysfunction causes can include trauma or non-trauma brain injuries, tumors, or drugs, street drugs that we tend to come into contact with, or I guess prescription drugs, street drugs that we come into contact more often than not for the other TBI related issues. We're looking for reversible causes such as narcotic overdose, or CNS trauma, which we would just be more supportive. And then we're evaluating their breathing pattern to kind of get an idea of what the underlying condition might be. Are we seeing chain Stokes? Are we just seeing apnea or other type of breathing patterns that we may have reviewed in the past? Management is going to be general management as discussed in the first, I think, couple slides of this presentation. We're going to be maintaining their airway and supporting their breathing, and holding C-spine or maintaining spinal precautions if we think that there's a injury to their spine. So dysfunctional spinal cord nerves and respiratory muscles, parasympathetic nervous system problems affecting respiratory function can include trauma, polio, myasthenia gravis, virus infections, and tumors. I was looking up a case of botulism, but that's not so much. I mean, actually, it'd probably fall into the PNS. It's more of it's not a CNS issue, but botulism being that those people that home can, if they don't properly heat up their canning material, that they can be ingesting botulism spores. And then also the reason why they recommend infants not to eat honey. You want to rule out any traumatic injury and assess for numbness, pain, or signs of parasympathetic nervous system dysfunction. Management is going to be our general management, as mentioned earlier, with support of their breathing and their ventilations if necessary, and then maintaining C-spine precautions again, if you think that there's a chance that they may be compromised. The spine has been compromised. Hyperventilation syndrome. These are patients that they're going to present with tachypnea, chest pain, numbness. They can have circumferential paresthesias around their mouth, around their face, potentially. It might be in association with the environment, that something that was stressful to them or anxiety producing had just occurred. As they hyperventilate and their end tidal CO2 reaches 25 or lower, they might develop the numbness and tingling and disorientation, as well as the carpal pedal spasms. As they're blowing off their CO2, they are decreasing their ionized calcium. But don't be fooled that all that causes carpal pedal spasms is not psychiatric in origin. Here is a list of things that can lead to hyperventilation and is not benign. So getting a good sample history, OP-QRST history as well will help you in identifying what you're dealing with potentially. The patient may appear to be anxious, nervous, dizzy. They might have a multitude of other complaints. They oftentimes will complain of numbness and tingling affecting usually their hands and their mouth, but also their feet. and they their vital signs may indicate that they are tachycardic or tachypnic, but they have a normal SAT, and the end tidal CO2 will be helpful as well. Management, I know when I first started, they had, so maintaining the airway, but when I first started, I was told that, you don't give them any supplemental oxygen, you place a paper bag and have them breathe into the paper bag, and that's kind of not where medicine or pre-hospital medicine has gone away from that. It's more of supporting them. You may actually be giving them some supplemental oxygen and coaching them through the process to try to slow down their breathing, and you're reassuring them. All right, moving towards surface area complications leading to respiratory distress. Indicated by the purple circle of just the lung on the patient's left side. So we're talking about pneumonia, acute respiratory distress syndrome, and congestive heart failure. Okay, I think we're doing good on time. So pneumonia can be an infection of the lung. It's not always bacterial. It can be viral, and it can also be aspiration related. As the alveoli collapse, it leads to ventilation disorders. This image here on the right-hand side shows that in this patient's left lung, that as the infection sets in, that the alveoli are overwhelmed by fluid, purulent material, decreasing their ability to ventilate and to oxygenate. Our physical exam should include a good auscultation of their lung sounds, not in just the apices, but say at minimum 3 levels on both sides. And usually I recommend that if you listen to the right upper lung, you listen to the left upper lung as a comparison. You're getting, again, another good sample in OPQRST history. These patients oftentimes present with chills, fever, cough, malaise, or myalgias. They may be febrile, they may be tachypnic, tachycardic, hypoxic. Their breath sounds may have crackles, and there might be decreased air movement on the affected side. That might be what you hear when you listen to crackles. Management is going to be primarily supportive. You're going to be helping maintain their airway, giving them supplemental oxygen, potentially placing them on CPAP if you think that they're in respiratory distress, monitoring their vital signs, getting IV access, making sure to be cognizant of the amount of fluid that you're giving to them, and they may get antipyretics. If you hear wheezes or you think that their absent breath signs might be related to a bronchospastic condition, you can try a beta agonist, and then we'll be moving towards antibiotics and continuing the care that was provided in the pre-hospital setting. Next condition under surface area issues is acute respiratory distress syndrome. This is widespread inflammation of the lung. The image on the right kind of shows that there is not one focal area of the lung that's affected. Both sides of the lung are kind of opacified from the base to the apex. So it's a diffuse injury to the cells, to the surfactant function, to the immune system, and to the ability to clot. It leads to pulmonary edema from increased vascular permeability, which causes increased interstitial fluid and decreased fluid removal and impaired ability to exchange gases. This is a list of all the potential causes for ARDS, but sepsis and pneumonia are the most common etiology for it to develop. Once a patient develops acute respiratory distress syndrome, it's associated with a pretty high mortality, up to 50% risk for death. It can also lead to multiple organ failure and it affects the interstitial fluid, as mentioned before, because of the permeability of the alveoli. Symptoms are usually related to the underlying cause. As a reminder, the previous slide of all the potential underlying causes, but usually they're presenting with dyspnea, confusion, agitation, and abnormal breath sounds, crackles specifically. Try to manage the underlying condition that you ascertain from OPQRST and sample history from either the patient or the caretakers or those around the patient. You're providing supplemental oxygen and you're supporting their respiratory efforts. You can trial CPAP, but may need to move towards intubation in the pre-hospital setting. You're going to be making sure that you're monitoring serial vital signs. These are patients that are in extremis, and monitoring them on telemetry or our cardiac monitors. They may be somebody that you would consider albuterol or meds to treat bronchospasms, and consideration for steroids as well. Next case under surface area issues is congestive heart failure. So it's impaired cardiac output, allowing or preventing forward flow, so backing up into the lungs. The image on the left shows a heart that's succumbed to diastolic heart failure, so that it doesn't fill adequately because of the hypertrophy of the cardiac muscle and interventricular septum. The image on the right is systolic heart failure, so it doesn't pump out effectively because of the decreased muscle mass in this heart, because of dilation and ballooning. So these patients, you should be having them sit upright. A lot of times they'll prefer or really insist that they want their feet to be dependent, not on the bed. I know that becomes a little bit of a issue as we're trying to restrain or secure them in our vehicles, our ambulances for transport. So as best as you can to allow for them to decrease that return preload. Place them on CPAP with 100% FiO2. Consider PEEP with mechanical ventilation if you move towards intubation. And if their blood pressure is tolerated, so if their systolics are greater than 100, you can be administering nitroglycerin every 3 to 5 minutes, up to 2 times, as long as their blood pressure tolerates it. But be careful whenever you're dealing with a patient who has been taking Viagra or any other phosphodiesterase inhibitor, or might be also suffering from a right-sided MI, as this can lead to profound hypotension. All right. Any questions so far? We're down to the last 2. All right. Doesn't look like it. So oxygen carrying capacity impairment. This is going to be our toxic inhalation and PEs. Toxic inhalation includes inhalation of any kind of heated air, steam, or chemical irritants. It can lead to airway obstruction that is related to laryngospasms or to edema. And our assessment is going to be getting a good physical exam and history. So be listening, auscultating their lungs, looking potentially in their oral pharynx to get an idea of what type of edema that we're seeing, at least in the posterior oropharynx, and auscultating their neck for stridor. Determining the nature of the exposure and how long they've been exposed to that exposure, and if there was any loss of consciousness. Our protocols reiterate our knowledge of make sure your scene's safe, make sure that not only is your scene safe, that when you enter your scene that you have the necessary PPE to make you safe. So that's usually an SCBA. And then removing that patient from that unsafe environment as quickly as possible, as safe as it is for you to be able to gain access to the patient. And then using hazardous material protocols, or MSDS, and initial intervention and drug therapy, you may want to call medical control or poison control from the onset to help guide your treatment and transport. Assist their ventilations, provide them with supplemental oxygen, high flow, intubate if they need it, and monitor their vital signs. They may benefit from a balanced IV solution, and if there is any bronchospasms, a need for albuterol may be indicated. So specific toxic inhalations that you might be dealing with: chlorine gas or dust. Chlorine gas is going to be a yellow or green colored gas. It has an irritating odor. From what I can find, there's nothing more descriptive than that, in that it's heavier than oxygen, so it's going to be the more dependent part of the confined space that you're potentially in. You might come into contact with chlorine gas either as a disinfecting agent in swimming pools or when an individual mixes bleach with an acid. Treatment's going to be humidified oxygen and treat for any severe pulmonary edema or bronchospastic issues per our protocols. Cyanide inhalation, it can come in the form of gas or crystals. Most often, probably, unless it's an intentional ingestion, it's going to be gas. Sometimes it smells like bitter almonds, not always, and not everybody can smell bitter almonds, so don't use that as your way of identifying if the scene's safe. And that it's less dense than air, so it rises in a room. Signs of poisoning might include altered mental status, seizure, coma, tachypnea, apnea, shock, or vomiting. And treatment is going to be hyperventilating them with 100% oxygen in the consideration of giving them sodium thiosulfate. Oh, I forgot to mention cyanide inhalation. A patient might be exposed to cyanide in manufacturing, although patients that smoke are also exposed to lower levels of cyanide, but more often than not, we'll be seeing cyanide in fires, any kind of combustible product as a byproduct of combustion. And that there is natural forms of cyanide in cassava plants, lima beans, almonds, and our pitted fruits like apricots and peaches. Hydrogen sulfide is a colorless gas. It's associated with rotten egg smell, and that you'll come into contact potentially with hydrogen sulfide with adhesives or also with agriculture. It's similar to carbon monoxide because it affects the ability to bind, it affects the ability of iron in the mitochondrial cytochrome enzyme, so it affects our ability for creating cellular respiration. So you oftentimes will find that the patient will present in respiratory distress, respiratory depression. So you're going to be assisting their ventilations with our general management that we discussed in many slides now, and treat the seizures if they do develop under our seizure protocol regimen. Carbon monoxide inhalation. This is an odorless, colorless gas. It's also a product of combustion of carbon-containing compounds, and that there might be high levels in any kind of confined space, such as a mine, and automobiles, and poorly ventilated homes. I don't know if you guys have come up with this same experience, but I've been told that automobiles, current models, do not have the risk of carbon monoxide poisoning as older, later models, although from my search for this lecture, I didn't see that anywhere in my research. So just assume that automobiles are associated no matter what make or model. Patients might expose themselves to carbon monoxide from a suicide attempt, and there's always a risk to our pre-hospital providers. Carbon monoxide binds to hemoglobin with a higher affinity than oxygen, which leads to hypoxia at a cellular level. Don't rely on your SpO2 monitor for hypoxia with carbon monoxide poisoning because our SpO2 monitors for bound hemoglobin. So you can be falsely reassured that the patient is ventilated or oxygenated when they actually aren't. When carbon monoxide binds to hemoglobin, it forms carboxyhemoglobin. Your end-tidal CO2 will probably be a better marker for acidosis and a lower level of SpO2 or end-tidal CO2 value than you would expect. So SpO2 and carbon monoxide is not reliable. Focus history and physical exam determine the length and the length of exposure, what that exposure potentially is, to make sure that you remove that patient when it's safe for you to remove them and not put yourself at risk. And that these patients are oftentimes complaining of headache, altered mental status, confusion. They might be agitated, they might be unresponsive, or they might be having a seizure. One other thing that you should also be looking for is vomiting. That might be their only complaint, is a headache and vomiting. So carbon monoxide poisoning can be suspected in those symptoms discussed in the previous slide, but also if there's sick pets at the home. You can think of it as creatures that have a higher metabolism are affected faster and more severely. So that's why we're talking about pets. But the other thing is children have a higher metabolism. So my experience in some of the cases that I've seen is that grandparents are watching the children, the grandchildren, and the grandchildren are sick, but the grandparents aren't sick. That might give you an idea of, you've got multiple people that have difference in metabolism that might be related to an inhalational gas. So you're going to place them on 100% oxygen via non-rebreather unless you think that they could benefit from CPAP and they meet the criteria. You'll be checking for CO levels in the home if possible, and that if cyanide is suspected, you want to know what their CO level is prior to giving them sodium thiosulfate. If their CO levels are between 3 and 25%, they will have neurological complaints, and you'll want to treat and transport oxygen to the emergency room, potentially put them on the cardiac monitor, get a 12-lead IV access. If their CO levels are greater than 25, pre-July 2020, we would be talking about maybe going to a hyperbaric chamber, but since July of this year, we are now transporting them to the closest appropriate facility because we don't have access to a hyperbaric chamber. The reason why hyperbaric chamber would be indicated if we have access to a hyperbaric chamber is because it offloads the carbon monoxide off the hemoglobin faster than just having them on high flow oxygen. So that should be 100%, 15 liters non-rebreather. So it offloads them faster than just oxygen. And then the other thing is it decreases the sequela of chronic neurological complaints. So that was the indication for hyperbaric chamber when it's available. And then you want to treat their symptoms per protocol. So if they have evidence of ischemia, which is oftentimes related to, you can think of a carbon monoxide poisoning, inhalational poisoning in an elderly patient is equivalent to a medical stress test or pharmaceutical stress test. You might see some ischemic changes on their 12-lead. Anyone have any questions about that section? I assume not. All right. And next is going to be PEs, or pulmonary embolisms. PEs can be multiple different etiology. It might be air, thrombus, fat, or amniotic fluid. It travels to the pulmonary arteries and becomes lodged and impairs blood flow and gas exchange. Risk factors that might be discovered during your sample history is that they've recently had surgery, they've had a long bone fracture, that they are pregnant, that they just delivered or recently delivered, a child. They might be on oral contraceptives. They might be a smoker. They might have had a previous history of a thrombus, either DVT or PE, or that they've had recent stasis, such as a long car ride or a long a transatlantic flight or something along those lines. So a good physical history and exam. So you would see this person that would be short of breath, but you wouldn't necessarily hear any abnormal breath sounds. They might be tachycardic, might be the only vital sign abnormality that you do find. They might also have some hypoxia related. They may have risk factors identified by your excellent history, and that they oftentimes will present with chest pain or just shortness of breath. Another thing that I find, maybe because I work a lot of nights, is that I get elderly, mostly elderly, but sometimes people in their 40s and 50s that get up in the middle of the night to go use the restroom and pass out, not sitting on the toilet or maybe associated with sitting on the toilet. And I have come to find a few more than just by rare chance saddle PEs in patients that were relaxed, probably normal blood pressure or low blood pressure, get up and they succumb to this thrombus that they had, and they don't necessarily arrest, but just have a syncopal episode. So syncope, something that you should also consider, especially if they had a maybe potentially lower flow or relaxed state preceding their syncopal episode. They may have some hemoptysis, and they may, on physical exam, may have some evidence of heart failure, either JVD or hypotension, and that there might be evidence of a DVT, either unilateral leg swelling or pain. Management is going to be protecting and managing, supporting their airway, giving them 100% oxygen to try to minimize the deficit that they have, intubate if it's absolutely necessary, establish an IV, oftentimes helping with some fluid. You're not talking about massive amounts of fluid, but some IV fluids might help with their hypotension, and monitoring their vital signs appropriately and transporting them to a facility that can manage their condition. I'm not sure if any of our docs are on the line here right now, but to appropriate facility would be anybody that would have anticoagulation, at minimum heparin, but maybe thrombolytics or interventional radiology if they want to do IR directed thrombolytics. Do we have Dr. Mock or Dr. Whitwer on the line?
Yeah, appropriate facility would be PCEP in.
Could they go to Legacy, Salmon Creek?
Because you need interventional.
They don't have interventional.
Likely.
Okay, so then appropriate facility, if you have a high suspicion for a saddle PE, is somebody that is the most severe form of a PE, would be to go to Peace Health. We have a protocol specifically for saddle PEs at Peace Health. I'm gonna forget the name of it. I think it's the PERT protocol, but we once we identify a PE, we contact the intensivist, ICU doctor, and the interventional radiologist. They review the history that I have received either pre-hospital and during the ER stay, and then they review vital signs and the CT images of the PE to identify what the most appropriate treatment would be, and that might be emergent interventional radiology directed TPA, or a staggered treatment, which is heparin, and then maybe going back to doing interventional radiology directed TPA in the next 24 hours. And then I forgot to point out, So this is a CT pulmangiogram. This is the main pulmonary artery. And then the CT angiograms produce contrast in the blood vessels. And then if there's a filling defect, that represents a thrombus. So this is a large thrombus, a saddle PE that is extending from the right and left pulmonary artery. So CPAP. It is a really great opportunity and treatment that we can provide our patients in the pre-hospital and the hospital setting that limits the, reduces the amount of patients that go on to intubation, that reduces the costs because they're not going to the ICU intubated, and reduces the length of stay as well. Sometimes that they have miraculous recoveries in the pre-hospital setting, as you guys have experienced. So it provides positive pressure through a mask. It's non-invasive. It expands the surface area of the alveoli through recruitment. It delivers oxygen to our patients, and it decreases the work of breathing, allows these patients to rest with their intercostal muscles and their other accessory muscles. End title CO2. So home stretch, everybody. Thank you. This is a non-invasive device for monitoring the CO2. It measures partial pressure or maximal concentration of CO2 at the end of an exhaled breath. In that it provides, if we have capnography, it provides a waveform recording of the amount of inspired and expired CO2. It can be examined at a breath by breath basis, or it can be used for long-term trends. It provides us additional information that is a good review for all of us to be cognizant about. So that spot check end tidal CO2 number can give us information about metabolism. How effectively is CO2 being produced? Is there evidence of anaerobic activity? How well are we perfusing our patients? How effective is CO2 being transported? In ventilation, how effective is CO2 being eliminated? This image here on the right is representation of a normal CO2 waveform. A to B represents the exhalation of CO2 from the dead space, CO2-free gas from the dead space. B to C is both the dead space and alveolar gases. C to D represents just alveolar gases, or exhalation of primarily alveolar gases. D is the end tidal point. This is the number that's usually reported, or that's reported. And then D to E represents inspiration, and that's when the CO2 levels drop back down. And a normal range is between 35 and 45. End tidal CO2 has a lot of utilization in our management and care. It can help with measuring the quality of CPR. Our greatest chance for achieving ROSC is if we have an end tidal CO2 value greater than 20, and that values less than 20 may be representative of inadequate CPR, either rate or depth, or fatigue, and which could represent fatigue of the rescuer and need to switch out that rescuer for another person that's not as that's fresh, especially if you're getting end tidal CO2 values of 20 with good CPR, and then you notice that it's starting to drop off. It can also predict prognosis with our CPR in our cardiac arrest patients. If it's persistently low, like less than 10, despite excellent high quality CPR, that it would be a predictor of lack of ability to get ROSC. And then end tidal CO2 levels of less than 10 measured 20 minutes after the start of ACLS accurately predicts death. A low end tidal CO2 means that resuscitation is less likely, successful resuscitation is less likely, but doesn't necessarily negate that that patient may be able to trend up and gain ROSC back. End-tidal CO2 helps us with ET tube placement. The waveform with all 4 phases indicates that the ET tube is through the vocal cord, but it could represent that it might be right main stem, but it's at least through the vocal cord with 100% sensitivity and specificity. If you have an end-tidal CO2 reading that you suddenly lose a waveform, this may represent a dislodged, kinked tube, or the ET tube has been disconnected. Or if you never get a waveform, it could represent that you have an esophageal intubation. But it also may represent that there's a complete obstruction. And a decreasing end-tidal CO2 after intubation, and you're not doing CPR, may represent a cuff leak or a partial obstruction. And then you can use the end-tidal CO2 with our supraglottic airways. So end-tidal CO2 with intubation allows us to have continuous information about the tube location during transport, especially if there's a lot of movement or the patient needs to be repositioned. And also can help us in identifying if our ventilations are too fast or too slow, and making sure that we are maintaining goal end-tidal CO2s for certain conditions such as intracranial bleeding TBI patients. It can be used, end-tidal CO2 can be used with our COPD patients. It'll show the hypoxic drive in COPD retainers. 5% of COPDers have a hypoxic drive, not all of them. So if you are using an end-tidal CO2 early in your management, if you see it to start to rise, you can cut back on the oxygen so that you don't end up having a hypercapnic patient that is too obtunded to protect their airway. In end-tidal CO2 and asthma, it also can help you with your management. If you have it on early in your course, you can use it to see how well your interventions are working, or if your patient is worsening despite your interventions. So with mild asthma, CO2 will drop, end-tidal CO2 will drop because they hyperventilate to compensate for their dyspnea. But as they progress or worsen, their end-tidal CO2 ends up becoming in the normal ranges, which should alert you to that your patient's condition is not improving, and that as they become nearing respiratory arrest or fatigue, that their end-tidal CO2 continues to climb and becomes actually elevated. And then last slide is end-tidal CO2 can also be helpful for low flow states. So specifically for shock, sepsis, it can be used as a diagnostic tool. In low flow states, you're moving away from aerobic metabolism and moving towards anaerobic metabolism. So your energy production is inefficient, and instead of getting 36 ATPs with aerobic metabolism and anaerobic metabolism, you're less efficient. So you're making down to only 2 ATPs, but you have a significant increase in lactic acid production, which leads to metabolic acidosis. Our body compensates by, or most patients, their normal response is to have an increased respiratory rate to blow off that excess acid. So our end-tidal CO2s may be significantly low in our patients with low flow states such as shock or sepsis. And that end-tidal CO2 level is inversely correlated with a lactate level and representation of organ failure. And that should be the last slide. Thank you. Any questions? Let me look at the comments. There's 2. Yes. If you have any questions, you can send it via the chat function. You can always email myself or the MPD office if you have any questions. That was a lot of material, and I appreciate your guys' attention and time. And if there's anything that I can clarify, please don't hesitate to reach out.
Thanks for doing this morning, Jackie.
Thank
What's that?
you. You
Yeah.
covered an incredible amount of material.
I felt like it. Awesome. Well, you guys have a great day. And wait a second. There's Dr. Bell had said that we have IR coverage always. Yes, we do at Peace Health. All right. Thank you, everybody. Have a great morning. Don't get blown away.